we're going to come in from an oblique angle. This is the needle going into the abscess. I get pus back, and I put a drain in. This is the tip of the drain. This is the drain coming in. There it is. It's in there. Now remember, we used almost 200. 200 was the dose-length product for that. 34. Now, before I got interested in this, maybe 5 years ago, they would have used diagnostic level MAS to do that, and the dose would have been quite high. Lung cancer. I treat lung cancer at our place by ablating tumors in the lung. This is a PET scan, obvious hot lesion in the lung. Now, I'm going to show you two pictures. This is an RFA probe stuck into that lesion. I also had to biopsy that lesion, and although it looks really easy, oh, you just take that and stick it straight in there. It ain't so easy. It takes some time. Nice picture from the side. You can see where the biopsy needle was and now the ablation probe is. And we heat this tumor up and kill the tumor and then take it out and pray for no collapsed lung, no pneumothorax. Now, even that, I got away with a DLP of 418. Why? Because I used low MAS. 17 is about as low as I can go, but I try to use as low as possible all the time. You can see the tumor, you can get the job done, and you deliver a reasonably low dose. How about complex biopsies? Everybody's at a place that somebody's doing biopsies. So, to orient you, this is an MR. This is the aorta, big red. This is big blue, the IVC. In between the two of them is a blob that shouldn't be there. This is a poor guy that has HCC, hepatocellular carcinoma, primary liver tumor, and it's metastasized, probably, to that node. So I want to drive a needle into that node, but not into the blood vessels. So again, we flip him prone. Now again, if you go back to this, it's obvious. The kidney has contrast, the aorta, the celiac. It's obvious where the blood vessels are. Everything's well defined. Now this is MR, and we go to our non-contrast CT with relatively low dose. You can still see